Have you ever thought about becoming a CRNA? Today, we are speaking with Beth Quaas, Associate Director of an Anesthesia program in Minnesota, Director on the Minnesota Association of Nurse Anesthetists Board, and practicing CRNA. She shares with us her journey from associate degree nurse to CRNA, tips on getting into CRNA school, and what it is really like to work as a CRNA.
Welcome to the Stay at Home Nurse Podcast. I'm your host, Deanna Cooper Gillingham. For over 25 years, I've strived to use my nurse credentials to find work that fit my lifestyle, whether it was raising my 4 children and 3 fur babies, traveling the world, or moving to Mexico and living on the Caribbean Sea. Sometimes I succeeded, and sometimes I failed, but I always learned from the experience. Now, I want to help you by sharing what worked and what didn't work. There are so many opportunities out there for nurses today. The Stay at Home Nurse Podcast will inspire and equip you to have a nursing career that is meaningful and supports your lifestyle. Now let's get started.
So today we are talking with Beth Quaas. Beth is a CRNA, and I'm going to let her take it from here. And Beth, would you go ahead and introduce yourself?
Yes, thank you so much for having me, Deanna. I am so excited to be here. I've been in nursing for 30 some years, and I went into anesthesia in probably 7 years into my nursing career. I've been a CRNA since 1999. I worked as a CRNA for 22 years. And then I kind of morphed into education. And in that time that I was a CRNA, I also served in some leadership roles, educated in an FNP program for a while, and now I am actually teaching student CRNAs.
Wow, that's very broad. So you've kind of started at the beginning and worked your way up.
I have, and I started in very rural Minnesota is where I am now. And I've kind of worked myself into the urban landscape of anesthesia and OR and education.
Sounds very interesting. So I think that every nurse at some point or another has thought about becoming a CRNA. At least it's crossed their mind because, all your patients are asleep. The joke is, haha.
Yes.
And so I'd like to hear a little bit about, let's start off with how you made the decision to become a CRNA. What was that decision like for you?
I was working in that little hospital up in northern Minnesota, and we had a patient in the little ICU that we have that needed to be intubated. And we called in our CRNA, and I really didn't know much about what they did at that time. But when he came in that night, he went to the refrigerator and he got a special bag of drugs that I didn't know anything about. And he used them to give to that patient and intubate them. And it was just so smooth. And I thought, I need to know more about this. And so that person is what spurred me to look into it and move on. And from that night, that was my goal.
So that was your goal, but it wasn't, I'm sure, just an overnight transition. So tell us a little bit about how that transpired.
Sure, that was years in the making. So from that point, I was a 2-year RN, and I knew that I had to have my bachelor's degree to move on to go to anesthesia school. So I finished my bachelor's degree while I was working. And then I moved to a bigger city into an ICU. You have to have at least 1 year of ICU training, but 2 to 5 is really ideal so that you get in. And it really needs to be in a big, busy ICU where you're taking care of very critically ill patients. That will serve you best in anesthesia school. So I did get into a bigger ICU, and as soon as I hit my year mark, I applied to an anesthesia school a couple hours away. And I was fortunate enough to get in the first time, which shouldn't scare people because it is so more competitive now that it can take a couple years to get into school. That shouldn't be a deterrent, though.
So you say a couple hours away. Did you have to move to go to school?
I did. I moved at that time when we started school. It was a master's degree, and you were busy in either class or clinical 40 hours a week, but then you can add 20 to 30 hours a week on top of that for studying. So all of the clinical sites that I would be going to were in the Twin Cities, which is where I moved to. And so it's not really recommended that nurses work while they're in anesthesia school. Things have changed a little bit. We've just finished transitioning from the master's to the doctorate. And so all programs starting now on will be a doctorate degree. So the program I teach in right now, the first year is totally didactic, so all classroom. I know some nurses that can do both. They can study and get the classes done with passing grades. And for others, it needs to be full on school and studying. So there isn't an opportunity to work outside of that.
So that's really good to know for nurses that are considering this, because it sounds like you have to either have another income coming into the home, or you have to have a nice little cushion to live off of while you're going to school on top of the cost of the school.
Absolutely. You have to do a lot of planning to be ready now, because the time commitment, I would say in most programs, are at least 36 months. And so if you take that time away and say you're not working, you really have to pre-plan. And so for some people, that means putting off school a couple of years until they can save up enough money to make sure they can live on that. Of course, there are loans, but whatever you can do to prepare so that you don't have to be stressed out about that piece of it. You can focus on school and clinical and not be so worried about that. And I would say in our program, that is one of the questions we ask at our interview. Have you thought about your finances and how you're going to pay for this? Because we don't want to admit someone that is going to be their focus, is trying to make money when really they need to focus on their studies.
That's interesting. So is this a program that once you start, you need to complete all 3 years right out the gate? Or is it something you can work a year, go to school a year, work a year? Or are you committed to 3 years?
You're committed to 3 years. There are some circumstances, should you have to drop out for family reasons, personal reasons, you can take a break and start with the cohort behind you if you left in good standing, because we don't repeat classes. It's not like if you don't take it fall semester, it's there in spring. It's each semester is set. So once you start, you have to finish in that progression.
Okay. Very good information. So you finished your school and you're ready for your first job as a CRNA. What was that like? Were you able to get a job back where you originally lived? Did you want to? Did you want to move back home? Tell me about that.
I did. I moved back to where I left as an ICU nurse. So that was midway up the state in Duluth, Minnesota. I worked there, like I said, for 22 years. I was fortunate at that time when I went to school, there was a shortage of CRNAs, and that is the same today. So I got a stipend through, I committed back to my hospital, and I was given a small stipend to go to school at the same time. So when I came back, I had to give them 2 years, and I stayed for 22. So I think nurses today can work with their hospitals, and I think they can get some financial incentives to go back to school and have a job when they get out.
So that's nice. That worked out very well, I'm sure, financially. And just knowing that you had a job when you got out, you were not going to have to worry about that aspect of it. So we've kind of covered everything up until working as a CRNA, but it's a huge commitment, both financially, time-wise, and I'm sure just the learning, it's a lot for this one specific thing. So anybody going into it would need to be pretty sure that it's a job that they want to do for 22 years like you have. So what is it really like? I think sometimes we glorify things, we make them seem a little bit better than they are. Is it as good as it looks? Tell us the truth. The good, the bad, the ugly.
Yeah, you have to have the right mindset. It is, we kind of joke about it, it's 99% nothing and 1% sheer terror. And when we hear from people, well, they just sit on the stool back there and don't do much, that's because we come out so well trained that a heart rate in the 30s doesn't really bother us because we know what to do, or a blood pressure in the 60s, we have the medications to give. And so I think the preparation that we do in school prepares us to make it look much easier than it is, when in fact, there's a lot of times that we have very nerve-wracking cases that to everyone else in the room might think that it didn't look like it was much of anything. I think that's just shows the education and the clinical expertise that we have learned throughout our programs, no matter where we went.
So I'm thinking that's actually maybe part of your job is to keep cool, keep calm, even when things are looking like they might go south, because in an OR, the doctor needs to be concerned with the procedure he's performing. And if I'm not mistaken, your job is really the patient, everything else around the patient that's not involved in that surgery and keeping them hemodynamically stable. Am I right with
Yes,
that?
spot on. The surgeon is focused on, you're right, the procedure that they're doing. They do not have the medications available to them to keep those patients stable. Anesthesia really is the one keeping that patient alive. So that's a lot of stress. This is a high stress job for sure, and that's why ICU nurses make perfect CRNAs, because they know the stress. They've seen it. They've used a lot of the drugs that we need to keep our patients hemodynamically stable. And I would also like to just say that CRNAs are nurses first, but we are independent anesthesia practitioners. We do not work under anyone. In some of the bigger facilities, we work as a care team model with anesthesiologists, but in most of rural America and all of the military, CRNAs are independent practitioners. We decide what drugs we're going to give. We decide the anesthetic we're going to give. And so in the bigger institutions, we do work as a care team. But I want people to know, if you go to school, you're going to come out being able to do your own anesthetic depending on the facility you decide to work in.
That's very interesting. I was not aware of that. So you're not working under the anesthesiologist.
No.
You are your own practitioner. So you're an advanced practice nurse.
Yes, we are. Yes.
Wow.
And, at the facility that I worked at for many years, it was the care team model. And so we had anesthesiologists, and they would be one anesthesiologist over 4 rooms with CRNAs in them. And so that's the care team model. And it really only has to do with billing. It's just the way that the hospital bills for the anesthesia. If I go down the street 2 blocks to a CRNA only facility, I'm the only one there taking care of that anesthetic and billing for my own time. So it's really just a billing model. It's not a supervision model.
So would you be able to start your own practice and say work with physicians, let's say maybe a plastic surgeon who does procedures in his office? You'd be able to go in there and contract with him and bill independently?
Absolutely. It's done every day. Dental offices, dermatology offices, GI clinics, any clinic really, hospitals, rural hospitals. We can go in and be the only practitioner and bill independently.
Very nice. So this sounds like almost like you could start your own business
I
once you
know
have
many
this.
people that own their own business. Yes.
Okay. Okay. Very good. So what about you? Have you chose to go down the business path or have you chose to stay as an employee?
I have chosen to stay as an employee because now I am in education. If I were out working just clinically, I would choose to be my own business owner. And that means I can contract with other places and bill. They may still do my billing, but I can charge a higher rate because they are not giving me any benefits. I'm not getting
Okay.
health insurance. I'm not getting continuing education and things like that. So right now, that is why I choose to be an employee. I don't work enough hours to go the business route. That is kind of the shift in anesthesia right now for CRNAs. Many, many people are becoming their own business owners and forming LLCs.
Okay. So I want to go back to you're now teaching.
Mhm.
And you mentioned that, the students and what they're looking for in students. We kind of brushed on that, but I want to go back and kind of circle back to that because if somebody's listening and they're like, yes, this sounds exactly like what I would like to do. Right now, for somebody going into school, what are they looking? You mentioned they're looking for ICU experience in a
Mhm.
large hospital. What else are they looking for?
Of course, grades are just as important. If you don't have a GPA above 3.0, that's okay. Then look to take some classes and get your GPA up. Don't, I would say in today's competitive world for students trying to get in, don't think that your ICU experience is going to trump your GPA. So if you have a GPA that is 3.0 or less, take some science classes, get hopefully A's, but B's if you can to bring your GPA up, and then push your application off until you can do that. But that would be my one suggestion. Shadowing a CRNA is another great idea. And I know during COVID, it was impossible to get into an OR. I think people are easing up now. So if you're in an ICU and an anesthesia, a CRNA comes in to drop off a patient, start up a conversation with them and ask, what's the possibility of me coming down and shadowing you? I think that's a great way to get a feel for the OR. The OR is a totally different animal than anywhere else in the hospital. And I've talked to many people from different areas that have been in the OR, and it truly is its own animal.
So that brings up another question. How much time we know and see anesthesia works in the OR. But as you mentioned, you got interested in this when they came to intubate a patient. So tell me all the different roles and responsibilities that the CRNA would have.
Sure. The operating room is just one area. Coming up to the ICU for intubations. Sometimes we'll come up and do sedation in the ICU for procedures, percutaneous tracheostomies or other things. We will go to interventional radiology. We'll provide sedation or general anesthesia for patients in those areas. Freestanding GI labs, GI clinics will go out and provide anesthesia to those patients. Of course, education is certainly needed today, and with the new doctorate degree that is being required will help ease some of that shortage as well. I think anywhere that sedation is found, you will find anesthesia.
I know I usually talk to our anesthesia because in the OR, it's kind of hard. There's a lot going on, but I worked in labor and delivery. So they came up and did our epidurals. And the
Yes.
patients were so happy to see the anesthesiologist or
So
CRNA.
so rewarding in OB because those patients are almost instantly happy. You're right. OB is a huge portion of what we do.
So is there anything that an anesthesiologist can do that you cannot do?
Can do, no. I would say in the bigger centers, sometimes they have cardiac anesthesiologists and they will run a transesophageal echo by themselves. CRNAs can do that. I would say in the bigger centers, though, that is for anesthesiologists. And I do not say that anesthesiologists aren't needed because they are. And I love working in a team. I've done it for decades. But I don't want anyone to think anesthesia, you don't have to know what you're doing because someone is telling you. That is not the case. We are independent practitioners and we make our own decisions.
So personality wise, setting aside all the other qualifications that you have to have, then you're saying you have to be someone who is able to make a decision on their own.
100%. If you waited for someone to get to the room, patients would not have very good outcomes. You have to be able to make a split-second decision.
Okay. So this is different than some nurses might experience. I think different hospitals are different in the amount of autonomy and letting you work at the top of your license. Some hospitals are better at that than others. So I think ICU is a great place because you are allowed to titrate medications, which means you're not calling the doctor and saying, we need more. Or they're overs, like you're titrating and you're doing those things on your own. So it's giving you a taste of what it's like to look at numbers, look at a patient, make an assessment, and then make a decision based on that assessment. And it sounds like that's what you do all the day.
Yeah, that's a really good point. I would say to nurses that are considering going to anesthesia school that are in the unit, step out of your comfort zone. Take those really sick patients. Titrate their meds to what you think they need. Don't be the first person to call immediately try to figure things out on your own, try to do a differential diagnosis. And I don't mean by, not calling when you think you should, but step out and try to make some of those decisions on your own. Because when you get into anesthesia school, when you're in clinicals, you're going to be working with a seasoned CRNA. But as soon as you're out, and they will push you too, they'll push you out of your comfort zone to make some of those decisions on your own. Don't be afraid. Take the sick patients now when you're in the ICU.
I think that's really good advice. So I want to transition a little bit. In addition to all the things that you've mentioned that you do, working as a CRNA and teaching, you also have your own podcast.
I do.
So tell us a little about that.
Before COVID, I was the director of a 60 CRNA group, and I did that for a few years. But trying to be in that middle management role where you're working with your group and trying to also follow the rules of the administration, I truly did get burned out from that position. I went back to clinical practice right before COVID hit. And so I came back to clinical practice in the same facility that I was a director in. And I thought, I'm so burnt out, I can hardly make it to work. And I'm hearing so many other people say the same thing. What can I do? And so I thought, I have a story to tell, but I know so many other people that do as well. And I want nurses to hear that they're not alone, that we all can relate to something. We're all going through the same thing, no matter where we work, the OR, the ICU, med surg, home health care. There was just so much going on. And so I decided to start that platform. My podcast is called Don't Eat Your Young, because I saw a lot of bullying as well, especially in the OR. I've had a few nurses that work as circulators in the operating room, and that is one of the hardest places to work and learn as a new nurse. And they will all tell you that the OR is one of the places for the most amount of bullying. And so I wanted them to share their stories, and I want nurses to know you're not alone. I don't want you to leave nursing if you can get around that and continue on. And so that's where Don't Eat Your Young came from.
So you have been doing this for 3 seasons now?
Yep.
And tell us a little bit about maybe your favorite story or podcast. Do you have something that's your favorite that you'd like to direct people to, maybe as the first one that they might want to listen to?
I have to say, I've met so many incredible people, so many incredible nurses that are willing to speak for other people and speak out against what we see. I'll tell you, one person had been a nurse for a couple of years, and that person started travel nursing as COVID hit. And so that person was going everywhere to some of the worst places. And he told me about a nursing home he was at and the atrocities that happened that he saw in that nursing home with those patients without their families there was incredibly disheartening. And we felt it, and we all heard that going on in the news, but to hear it from that person's mouth brought me to tears, because it was so sad. And nurses went through that everywhere, not just in the United States, everywhere around the world. And we weren't getting what we needed, and no one was listening to us. The decisions were being made, but not by nurses. And so that is probably one of my most memorable podcasts that really struck my heart. But then I've also met some incredible nurse coaches that are out there trying to help nurses through burnout and showing them that you don't have to stay in a job just because you think you need it. And what you're doing is incredible, showing nurses there are so many other places you can put your expertise to work.
I think it's important. I notice with the newer generations, and I so respect it. Millennials get such a bad rap, but one of the things I really respect about them is that they don't tend to take on this burden that some of us Gen Xers and, of course, baby boomers, they take on a responsibility like, I have to do this. It's if I don't take this and carry this burden, nobody will. And I really have to appreciate the millennials who they work hard and they're
They do.
great and they know what they're doing, but they know where to draw the line and say, I also need to take care of myself. And I think us older nurses, and I don't mean older in that we've been practicing longer, because you can be a new nurse, but be in our generation, we can really learn something from them and how they are good about just drawing that line and saying, no, I'm not coming in for overtime. This is my day off. And where we feel like, oh, I saw a funny meme one time and it was like each generation and what happens when they're called in for an extra shift. And, there's the boomers that just go in because they feel like it's their duty. Then there's the Gen Xers who say, which was me, if you can't get anybody else, I guess I will. And then you had the millennials who were like, no, it's my day off. I have plans of going hiking. And it was like, wow, that is so eye-opening because it's the truth, but I think we really can learn something. And I think a lot of times as older nurses look at them and feel like they're not pulling their weight, but they're taking care of themselves.
That is so, that is such a great observation. And I will say, wearing two different hats as a director, hiring people, it wasn't the days of old when you hired someone and you knew they were there for their entire career and you could count on them staying for years. That's not the case anymore, but that's how it should be. If you are not at a good place or that's not the fit for you, why should you stay? And as an educator, I'm seeing a different student come in the door. It's not just that you sit up and lecture and everything's fine and they take a test and move on. We've learned so much from this generation. There are so many different ways to provide information and content to students. And me being of your same generation, I'm learning a lot from them about, I can't do things the way I've always done them. I need to keep up and learn these new ways to offer the same content. So that's an incredibly great point to bring up. We all have to adapt. And I believe that they are taking much better care of themselves than we probably have in the past because they're setting boundaries.
Yes, which we all should be doing. And I think it's interesting what you brought up about the way that they learn. They were born with iPads in their hands. They were born with phones. They are used to getting content in a different way than just the traditional sit in a classroom, lecture, read a book, and learn it. And it's not a bad thing. I think sometimes we're so, this is, the old meme about, like, well, this is just the way we've always done it. Why do we do it this way? Because this is the way we've always done it. And, I see some negatives to the way that the hospitals are turning right now because they're not always putting out nurses who know how to do things because they're trying to train them to pass the NCLEX. And
Yes.
for so many, in school, they're testing and it's just to pass the test. So we have a generation of young people who've only been taught to pass a test. And then they get out in the real world and there's no test at the end of that day to say whether you took care of your patient right or not.
Right.
And so, there's pluses and minuses, but I like to focus on the positives. And I think the positive things that we can learn in our generation of nursing is draw boundaries. It's okay to have boundaries and say, no, I don't, I'm willing to work this much overtime in this amount of period, but I'm not willing to do this. And it's okay. So you've interviewed a lot of people.
Mm-hmm.
What are some words of wisdom that you can impart with our audience on some of the things that you've learned?
For interviews, I would say for nurses coming in to the hospital world, CRNAs, I'll speak for CRNAs, be flexible when you're first coming in and learn the system. And we're not asking you to do more, but we are asking you, this is what we offer, and can you do this? As you move in and get more experience, then I think you can set more of your own boundaries. But I would say in anesthesia, you have to be a competent practitioner. And we all have to prove ourselves first. We know that for sure. Interviews for students coming in, you have to be able to look at yourself and decide where you're at and what's being asked of you, and you may have to adapt to some of that. That's not so much drawing boundaries, but being able to be better at time management, be better at organization, and you're a self-learner now. You are an adult learner. This is not undergraduate school, and it is so different. So for anyone that wants to go to anesthesia school and thought that their undergraduate nursing was not too hard and they got through just fine, you have to look at what you're going into because it is completely different. You have to be okay with maybe getting a B or not passing an exam because you will not get A's on every exam. So there are things like that. I hope I answered your question correctly.
That was very good. That was actually really good. And I think that brings up another topic, and that is the profession of nursing. And so when you said about you're an adult and a self-learner now, that is something that you have got to embrace. The patient in that bed is counting on you to know what you need to know. And when you get to our age and you've been a nurse for decades and you're counting decades instead of years, things change. Medications change, tests change. And you have to, as a nurse, keep up with those changes. And it's your responsibility to be a self-learner. And I think one of the things that I see is everybody, as a professional, this kind of came to me the other day. I was talking to other professionals. You talk to accountants and you talk to attorneys, and you talk to other people, and they take responsibility for their own education and their own learning. And if they want to, become a certified public accountant instead of just an accountant, they're going to go to school and they're going to learn and they're going to do what they need to do. And what I find with nursing is it's always like, well, when you ask them to get certified so that you can, move up and be more competent in what you do. I know how much I learned when I became certified, just studying for the test. I became such a better case manager because I learned so much that I would have never learned in such a short period of time. It like exponentially grew myself in my profession. Nursing is one of the few professions where we want the hospital to take care of us. We want the hospital to provide the continuing education. We want the hospital to teach us everything and take care of us, but yet we want to be independent and we want what we want. And so I don't know, what are your thoughts on that? I'd just like to, since this is a new thought that I've had, I'd love to hear your opinion.
I love that. And I do have thoughts on that. We call ourselves professionals, and that means something. And if you're a professional, you have to be okay with some things that aren't provided to you, and you have to figure out how to get what you need. I think that is one thing that we need to be better at. If we're going to ask for certain things, then we also need to give certain things or offer certain things. And that could just be, it doesn't have to do with coming in and working more, but teaching someone something. If you know something, don't say that's not my job. No, just go offer it. Offer something, help someone out. And I think we need to do better in our education of teaching nurses what that means to be a professional. To be a professional doesn't mean that you're going to be taken care of every second of the day. And I don't mean to not say hospitals are responsible for certain things, but we also have to be able to give back to our employer if we are expecting certain things from them. When I decided to call my podcast Don't Eat Your Young, young doesn't mean young in age. It doesn't mean young in experience. It means that you've moved to a different space. And so just as young nurses will say, well, this older experienced nurse was so mean to me and they bullied me, there's also bullying going from the younger generation to the older generation. And so don't eat your young to me really means be professional, share everything you know, because there are things that you don't know that someone can teach you. So listen and be respectful.
And I love that. And I love the whole idea of, don't eat your young, be there for another. As a professional, you need to help our profession. So it makes me so proud year after year to hear that we're one of the most trusted professions. We treat our patients well. The general population has a very good impression of us, but it's embarrassing how we treat each other.
I was just going to say, if some people had a camera in a break room some days or heard the gossiping outside a patient's room or something, you don't see that in physician groups.
No.
So why would we see it in our own groups?
Right. You don't see it in accountants. You don't see it in attorneys. You don't see it. And so I really want to, if nothing else, people listen to this podcast. And I like to think our listeners are probably a little bit above average or a lot above average. So maybe it's not you, but maybe you need to call out another nurse that's doing it and say, you
Yes.
know what? Rising tides raise all boats. And if we want to rise, if we want management to look at us and respect us, we have to respect each other.
Right.
And the example I always give is when, because I've seen this so much and people don't see it as bullying, but when the doctor says, who did this about a patient? Who said this patient could have whatever or do whatever or whatever? And they'll be like, oh, that was so and so, and they're blaming another nurse or calling out another nurse. And what they don't realize is that makes every nurse look bad because the doctor doesn't really know or care that it was Cindy. What he says is a nurse did this.
Yes.
And so you have brought down every nurse by making that one comment.
Right.
But I'm not saying that you have to defend somebody for doing something that's wrong, but half the time it wasn't something wrong. Half the time it was something silly. Like they let him go to the bathroom and the doctor said, well, I didn't write the order, but another doctor did write the order. But you know that I don't like my patients getting up until day 3 or whatever it is. It's something stupid. And instead of defending each other or even saying nothing, just saying nothing, why do we have to call out somebody else?
That is so true. Why do we do that when all we have to do is, like you said, either say nothing, say, let me find out what the story is and I'll get back to you, or I'll have someone come and talk to you about that. But you're right. When we don't defend each other, it makes us look just as bad. And I'll say, as a young nurse, I needed someone to defend me and help me and protect me, just as we do the young nurses coming out. School is so much harder than it used to be because there's so much more content. And so we need to help those young people find their voice, become confident, and just stand behind them a little bit and nudge them so that they can grow into being more of a professional.
And one day, most likely, if it's not us ourselves, it's somebody we love, is going to need one of those nurses that are the new nurse right now. It could be us, it could be our children, it could be our parents. And we need to be empowering them to be the best nurse that they can be so that when they're taking care of our loved ones, they know what they're doing.
I totally agree. That's what I want. That's what I want for the people taking care of me.
Right. Okay. I think that's a great place to end, but any last words of wisdom, anything that you'd like to share? I definitely want you to share your podcast and where people can find you, but anything else that we didn't cover that you wanted to cover? Or
I just want to tell nurses out there, if you don't love your job, if you wake up sick and you don't want to go there, please find out what's going to work for you. Do you need a different job? Do you just need some support? Take care of yourselves so that you can be healthy and take good care of patients as well. You can find me on anywhere that has podcasts for Don't Eat Your Young. I have a Facebook group called Don't Eat Your Young. I'm on Instagram under Don't Eat Your Young, and I'm also on LinkedIn under Don't Eat Your Young.
I love it. I love it. Okay. Well, thank you. I hope people will go and listen to your podcast, and I hope that they'll be encouraged. And again, every decision we make, every time we lift up one of our coworkers, another one of us, another nurse, we're doing something good. So let's go out there and let's do a lot of good this week.
I love that, Deanna. Thanks so much for having me on.
It was great. I really loved it. Okay, everybody, have a great week.